So this is a video on breast cancer. So breast cancer is a cancer in usually epithelium, but could be in the connective tissue of breast. It's found on in chapter 10, page 19, all the way through to 31 in your textbook. So it's the second most frequently diagnosed cancer in women. I believe lung cancer is first. There's a lot of diagnoses per year and quite a few deaths. About 1% of are found in men. So for women, especially white women, lifetime risk is 1 in 8 of developing breast cancer. That's just normal. For young women, it's about 1 in 20,000 to happen early, like for a 25-year-old. So it really is a disease that happens more with age. Most women are diagnosed with it beyond the age of 50. There's a falling away of the incidence, and there's a number of different theories that can attribute to this. One of them is kind of better screening methods. In the 12 years or so that it's dropped, the availability of MRIs and other imaging techniques is much better. Not only is it more available, but it's much more refined. Also, in the past decade, the idea of hormone replacement therapy has really changed. And they think that was a contributing factor before. And in the 80s and 90s, most women took hormone replacement therapy for symptoms of menopause, or perimenopause, actually. And now that's... Most cancers of the breast are ductal in nature. About 80%, according to your textbook, are found in the ducts that bring milk to the nipple. There are adenocarcinomas. They originate in that epithelial cell that lines the ducts. They start right in that spot, and then they invade the tissues around the duct. Far less common are the lobular carcinomas, and they actually start in the lobules. These are the glands that are actually the milk-producing glands. They again start in the epithelial cells of these milk-producing glands, and will become invasive into the surrounding tissues. There's a couple of other different types of things. There's inflammatory medullary and Paget's disease of the breast, which we will just mention. So the medullary carcinomas are fairly invasive. But they're much slower and have a better prognosis. Paget's disease is, we already talked about back when we talked about Paget's disease in the musculoskeletal system. So they start out as growths. They start out as small little mutations in the epithelial cells right at the site. And they grow slowly over time. They become malignant later. uh, they normally spread when they metastasize via the lymphatic system. Um, they can spread via the circulatory system, though, as well, but most commonly we think of it as lymphatic. So, what are the risk factors? There's a couple of risk factors. One of them is these breast cancer genes, and the names of them you can tell came fairly late. They're BRCA1 and BRCA2, which stands for breast cancer 1 and breast cancer 2. It's interesting because there's a lot of hype about this genetic basis to it, but it really only makes up about 10% of diagnosis that can be traced back to these genetic mutations. Really, these two genes, the BRCA1 and 2, are tumor suppressor genes. And when they're working properly, they produce proteins that keep that cell growth in check. When there are mutations to the genes become inactive, and so they don't so much cause breast cancer as they fail to prevent breast cancer that's caused by other things. Really, women have it way more than men, so being female is a big risk factor. Age definitely comes into play there. And it seems that it's another one of these things where it's exposure to estrogen over a long period of time. So this is people especially at risk are people that have their puberty early menarche, late menopause, and few or no pregnancies. I've discussed this in a couple of different videos where I talk about things have changed, and the number of women that get a lot more exposure to estrogen today is a lot different than it was even a few generations ago. There seems also to be a correlation with alcohol, and nobody really quite knows why, but people that drink on a daily basis have an increased risk. Weight gain and obesity are risks as well. It doesn't say that in this slide, but weight gain that comes later in life, so that comes in adulthood, if you gain more than 20 to 30 pounds, we're 40% more likely to have breast cancer after menopause compared to women who gain no more than 5 pounds. Interestingly enough, women that have been overweight since childhood don't carry a bigger risk. One of the things is that estrogen is a fat-soluble hormone, and it gets stored in fat. And so even postmenopausally, estrogen is released as fat stores are used. So estrogen keeps on circulating. So that adds to the risk, just because there's more estrogen and it's exposed for a longer time. Race and ethnicity is one. So white women are slightly more likely to develop breast cancer than African Americans. They say that Ashkenazi Jews who have a mutation in the BRCA genes have 80% chance of developing breast cancer by the age of 80, as opposed to 13% for the average 80-year-old woman. So this really heavily points to the to genetic factors. So if it runs in families. Even if you have all of these risk factors, though, if you've gained weight, if you're over 50, if you have a family history of it, if you've had no kids, and if you have these breast cancer genes, that still doesn't guarantee that you're going to get breast cancer. It's an increased risk. So one of the things about breast cancer is that these little tumors are pretty deep in the breast, and there's a lot of other tissue in the breast that's not involved, a lot of fat tissue that can hide the tumor. They have to be pretty sizable before they're palpable. So early on, it may be no signs and symptoms, and very, very difficult to detect except through imaging. Later, as the tumor grows, it becomes a palpable mass. And much later, what ends up happening is the skin starts to pucker at the place. It's called orange peel skin. Sometimes nipples invert. As the tumor starts to pull on the stroma, on the connective tissue, it starts to deform the breast a little bit, so that can be seen. If it's in the duct, it's quite possible that there will be a discharge out the nipple. And it's interesting because both my wife's grandmother and my aunt had breast cancer, and both of them were diagnosed the same way, and that was because of a discharge out the nipple. And my aunt, for sure, had mammograms and screening tests, although it had been a little while, so they had been missed. She had a number of nodules in her breast, and so they assumed, I guess, anything they saw was that. If it gets to the point of metastasis, one of the big problems is that it metastasizes to bone quite often, and you'll end up with compression fractures. And from the compression fractures, there will be spinal cord issues and neurological symptoms. So, how do they find it? The most important thing, actually, is self-examination. One of the problems with palpating is that if there's no baseline, if there's no kind of, you're looking for change, and it's hard to remember change. Now, in self-examination, you're much more aware. You only have to really keep track of one person when you're doing it yourself. So it's probably the most reliable thing. If you find something that wasn't there before or is changing, then you move on to second opinions and looking into it other ways. Mammograms are a very useful thing. Most women here in Canada get regular mammograms beyond a certain age. OHIP is very good at paying for that, and there are whole clinics set up for it. In other countries, it is less likely to be to happen, but whatever, we don't have to worry about that. It's us. MRIs are very good at visualizing them. They tend to do MRIs if something shows up on the mammogram or if there is a palpable mass that's found. It's it's a much clearer picture than just the X-ray of the mammogram. They do ultrasounds of them too. The the tissue is of a different density than the breast tissue, so it's it will respond to ultrasound that you'll be able to see it fairly well. Biopsy is the next step, and where they actually take a little piece of it and they look at it from a histological point of view and decide whether, like, what kind of cells are there. If it is breast cancer, and what they'll do, because it spreads through the lymph nodes, they will take the lymph nodes that are closest to the breast, which are called the sentinel nodes, and they'll look for signs of cancer there. If there is cancer there, then they'll take the next nodes in the chain and so on until they find how far it's spread. Now, most of the sentinel nodes are found kind of up in the armpit. Some of them are right behind the in the mediastinum. If the lump is in the kind of the medial lower quadrant of the breast, then they'll probably go to the mediastinal nodes. The rest of them tend to go up into the axillary nodes. So this is an MRI view of the tumor, and you can really see the connective tissue stroma in this picture, and see how the just what's involved in the breast. So you don't prevent it. What you try and do is catch it early. There's in prevention they talk about lowering the risk factors. Well, about the only risk factor, because you can't lower your age or being female or having a family history of it. So really the only thing you can manage is really alcohol and weight gain. So really it's all about early detection. So self-examination, mammograms, that kind of thing. Clinical examination on a fairly regular basis is a good idea too. If you have those other risk factors, especially a genetic predisposition, then being more vigilant is really important. I think the Angelina Jolie method is gone slightly to the extreme, but I guess she had sound reason to do it because she had a genetic predisposition. Although I would say that being 30 pounds overweight is not one of her issues. So what do they do for it? Surgery is the most common thing. So they'll do a lumpectomy. They'll take out just the tumor, especially if it's staged pretty early. They can do a partial mastectomy, which is taking out a part of the breast as well as the lump. A radical mastectomy takes off the whole breast. Modified mastectomies will take out kind of selective parts of the breast. Radiation is a big thing. External or internal. If the tumor is small, they may just inject radioactive seeds, like seeds of little radioactive isotopes, right into the tumor and try and kill it that way. Most often it's an external source in a radiation therapy machine. Um, chemotherapy is used often before the surgery to try and shrink the tumor so that especially if they're going to do a lumpectomy. And it's often used after as well in the case of metastasis. They try and prevent or slow down metastatic spread of it. The tumor cells really respond to estrogen. Now, one of the things that's interesting is that estrogen isn't a cause of these tumors of breast cancer. What it is a promoter. Once there's a mutation and once those cells are established as cancer cells, then what the estrogen does is it promotes it. It speeds the development of the tumor. And so one of the things that they've started to do fairly recently is hormonal therapy to try and bind the receptor sites on those tumor cells to prevent the estrogen from causing the tumor to grow quicker. There are various other drugs that are being used. They're called biological therapies, and it's really what they try and do is stop mitosis in those in the cells. I don't know very much about it. They I think are showing a pretty good promise, but I don't think that it's quite there yet. So a complication of the treatment is, especially of surgery, is something that you should be very aware of. As a matter of fact, I've just referred a patient who had breast cancer 3 years ago, who suffers from really bad lymphedema in her left arm and hand because of them taking so many lymph nodes when they took her breast, and that actually distresses her more than than having to wear the prosthesis. She wears long sleeves, and she tries to pull the sleeve down over her knuckles so just her fingers show, because she's really very self-conscious about how puffy that left hand is on her. One of the massage therapists at my office is now working with some lymph drainage with her, and hopefully she'll see some results. It won't go away, but maybe it will be manageable. People that have radiation end up getting burns and can actually get ulcerations. One of the things that radiation does is it kills cells that are in mitosis, and a lot of times the stratum basale of the epithelium, especially right in the line of the radiation path, die as well, because they're constantly undergoing mitosis. And so they can end up with ulcerations. The epithelium basically dies right there. Chemotherapy is now better than it once was, but it has been really rough. Again, the target of chemotherapy, like I've said before, is cells that are undergoing mitosis. So hair follicles are constantly undergoing mitosis, so hair follicles die and hair falls out. Nausea, because the mucosa of the stomach, the mucosa inside the mouth, the development of white blood cells in the bone marrow, all respond to chemotherapy and end up suppressing the immune system because there's not as many white blood cells produced. Think of if you're killing cells that are undergoing mitosis, how does that affect the cloning uh, during an immune response? Um, Sometimes, you're throwing the baby out with the bathwater with some of these things, because you can actually increase the chance of other cancers, or you cause blood clots and maybe pulmonary embolisms and that kind of thing as well. So all in all, it's there are complications of treatment, but it's way better than no treatment. Like it's the cure rates are really very, very good. If it's stage 0 or stage 1, so that's in situ, or no larger than about 2 centimeters, and hasn't spread outside the breast, it's 100% 5-year survival rate. If it's stage 2, it's between 92 to 80%. So if it doesn't involve the lymph nodes, and so there's no metastasis, we're talking about a 92% 5-year survival rate. If it's in the axillary nodes but hasn't gone any further than that, we're still talking 81%. It's not till we get to stage 4 with metastasis to other parts of the body, like bones, lungs, liver, brain, that we start to fall into low survival rates, like 20%. So this is all from table E10-2 on page 25 of chapter E10. It is actually very heartening what's happened in the last 20 years, because breast cancer was a really, really bad diagnosis at one point in, like, my mother's generation. In my generation, it's become less and less onerous. I mean, it's still serious, but it's like treatment options have gotten so much better that that people do well. Now we're seeing the incidence of breast cancer rising, and there's a little bit of kind of false statistics in those statistics, in that it is a disease that comes on with age. It's long-term exposure to estrogens. It's not short-term exposure. So it's a lifetime of exposure, so therefore you need to have a lifetime. Well, it's another thing to blame on the baby boomers, where the population is aging. There are way more women over 65 now than there ever were. Because that's where the baby boom's hitting right now. So breast cancer awareness has become a major topic, because of that's where the baby boomers are now. So what do you do with massage? Like I say, the lymphedema and those kinds of things really help. You got to weigh benefits versus risks before surgery, before while the tumor is still there and still active. I would probably resist any the temptation to do any lymphatic work, because it may speed up the spread. There's also kinds of quality of life things as well. So something to discuss with your in theory class.